so I will make you angry. So after এই আর্টিফিশিয়াল ইন্টেলিজেন্সের এত কঠিন কঠিন জিনিসের পর আমার এই জিনিসটা আজকে খুব সহজ হবে সহজভাবে বলার চেষ্টা করব। My topic is the management of the diabetes mellitus in the critical ill patients. Critical ill patients. Now in UK, diabetes patients in case of if I consider the hospitalized patient, near about 20% of the patients are suffering with diabetes or diabetes-related complication. And majority of the causes of hospital is diabetic ketoacidosis or hypersplenary state or the hypoglycemia or diabetic food or some complication or patient in hospital is surgery or something else and diagnosis he or she is suffering from diabetes mellitus. So hyperglycemia occurs not only patients with known diabetes but also in those not previously diagnosed with diabetes mellitus. It hampers the patient's outcome, mortality, and inpatient's complications, and the length of hospital stay, and overall hospital cost management. Now, what is critical ill? If a patient is critical, we say patient is critical is when their vital organs are involved, like our Rizan sir and our Rizan sir mentioned that there is a OKD patient, there is a lot of critical patient. So when there is vital organs involved, and if they, in that case, if there should be potential reversibility. If there is potential reversibility, this patient is known as critical ill patient. So critical patient, they are high risk of mortality, and we should try to combat the risk of the mortality. So inpatient hyperglycemia, what is the definition? With hospital hyperglycemia, we can say when blood glucose level is more than 140 milligram per day. And stress hyperglycemia, we say consider stress hyperglycemia when hemoglobin A1C is less than 6.5. So there is a recent onset of impaired hyperglycemia. If hemoglobin A1C is more than 6.5, then patient should be diagnosed in case of that considered should be he or she may be a case of diabetes mellitus. And we consider hypoglycemia when blood sugar is less than 70 milligram per day and severe hypoglycemia less than 40 gram per milligram per day. So in consider in hospital hyperglycemia, near 8% of hospital patients had hyperglycemia. So what is the pathogens of the hyperglycemia? When the patient is suffering from critical ill, in that case there is the increased release of the insulin and the lack of the insulin resistance or something else, and there is a lot of other factors. This leads to increased lipoprotein lipase, and there is a fat breakdown. The fat breakdown leads to the increased perifatty. This perifatty undergoes the gluconeogenesis and produces the glucose. And there's also increased metabolic muscle breakdown that increases the free fatty amino acid, and that also goes into gluconeogenesis and produces a lot of glucose. And there's also less glucose utilization. All these things ultimately leads to hyperglycemia. Besides this, hospitals critical patient may or may not go on IV glucose, that increased secretion of the catecholamines and glucocorticoids, and patient may go on parenteral nutrition. All the things leads to hyperglycemia. What is the end result? End result is hyperglycemia, that is the osmotic diuresis that leads to hypovolemia, decreased glomerular filtration rate, and prerenal azotemia. And hyperglycemia is associated with impaired leukocyte function, including the decreased phagocytosis, impaired bacterial killing, and altered chemotaxis leading to hospital infection and poor healing. And what is the outcome? If I consider the new onset of hyperglycemia, 16%, or if previous diagnosis of diabetes mellitus, there is an independent marker in patient hospital mortality. So new onset hyperglycemia is a very bad thing. So if I consider isocytic and non-isocytic, there is the same type of result. So type of hypertensive diabetic emergency. In case of diabetic patient suffering from the diabetic ketoacidosis, hyperosmolar state, or atherogenic hypoglycemia. What are the risk factors? Poorly managed diabetes mellitus, and if patient skip the meals or skip the overdose of insulin or skip the insulin and insulin delivery problems and illness, trauma, surgery, and drinking alcohol or drugs. Some drugs can cause this to hypoglycemia. So considering the considering the management of the diabetic emergency, so we should keep in mind that hypertension should be addressed, hyperglycemia should be addressed, and urocrine imbalance should be addressed. And identification of all the precipitating events and frequent monitoring is important. Otherwise, we can lose the patient. So, diabetic emergency management protocol, we should keep two things. Number one is IV fluid, and another is IV insulin. So, if I consider the blood sugar IV fluid, we should consider the blood sugar is less than 200 or less than 300. if blood sugar is less than 200 or 300 or more. If a corrected sodium is less than 135 and blood sugar potassium is less than 5, we can consider the normal saline and IV insulin, and after all potassium supplement. And if it's more, potassium is more than 5, there's no need of potassium supplement. And in case of glucose control, we should add IV insulin is the best option. And how long we should take that treatment? And when we can say that diabetes is resolved when blood sugar is less than 200 and two additional parameters like serum bicarbonate is more than 15 milliequivalent per liter or millimole, and venous pH is more than 7.3 and calculated anion gap is less than 12. And in case of hyposmolar state, we can say the previous criteria of the DKA, resolution and normal serum osmolarity. So what should be the diabetic glycemic goal in the hospital? According to the American Diabetic Association, it should be when should the treatment initiate the treatment. When blood sugar is more than 150 milligram per dl or 10 millimole, we should initiate the treatment. And in case of the should be the target? Target should be 140 to 180 milligram per dl. That is 7.8 to 10 millimole per liter. But in case of cardiac emergency or in major surgery, there should be stringent blood sugar control. In that case, blood sugar should be less than 140, that's within 110 and 240 milligram per dl. So, what is the treatment option? What is the treatment option? Treatment option is the goal of the insulin therapy is to reach the acceptable glucose targets in the shortest duration of the time and minimal incidence of hypoglycemia. To do this thing, we can add the IV insulin or subcutaneous insulin algorithm. And if patients are oral hypoglycemic agent, we should switch this. And insulin is the preferred agent for the glycemic control in the hospitalized patient. And isostatic, there's a lot of protocol. There's a Digami protocol, Van Denberg protocol, Portland protocol, Markovic protocol, Yale protocol, Stanford protocol, and the Duke protocol. A lot of protocol. But considering our neighbor country from India, with this conscious recommendation for the management of the hyperglycemia in the critical patient in the Indian setting, the recommendation goal is 140 to 180 milligram per dl. And sleep patient I have already mentioned, I'm going to repeat this thing. So it is not recommended to average the blood glucose level less than 110 milligram per dl in the critical patient with hyperglycemia. So in ISO setting, what is the recommendation? They recommend that start the intensive intravenous insulin therapy in critical patients when blood sugar is more than 180 and IV insulin is the best option. And start when the IV insulin therapy is the short-acting insulin and preferably with the infusion pump. And start the insulin infusion by dividing the glucose level. Thus, if I consider patient is admitted and patient's blood sugar is 280 milligram per dl. So what should be the dose? Dose should be 280 divided by 100, that is 2.8. Nearest figure is 3. So we give 3 unit insulin per hour. Okay, addition of the bolus insulin does dose is not recommended, and titrate the IV insulin dose according to the prevailing blood glucose value as shown in the table. I've already mentioned if it is 100 less than 110, no insulin, 110 to 149, that's 1. This same formula is similar formula I have already mentioned. Transition from the IV to subcutaneous insulin therapy. When we should switch this thing? To maintain the effective blood glucose level, it is necessary to administer the short and rapid-acting subcutaneous insulin 1 to 2 hours before the discontinuation of the IV insulin, and in case of intermediate or long-acting insulin, 2 to 3 hours before the discontinuation of the IV insulin. So, what should be the insulin protocol? Sliding scale or basal bolus therapy. In a lot of our endocrinologists in clinical setting, they use the sliding scale therapy, but in conscious health, it is not generally recommended. And we should use the basal bolus therapy preferred. So non-particle hesitant or regular insulin we can use, and long-acting or rapid-acting insulin, this type of combination we can prescribe. Do we use the sliding scale insulin nowadays? According to the consciousness, use of a correction of the or supplemental insulin without the insulin, often referred to as sliding scale, in patients is discouraged. So this effectiveness of the sliding scale insulin is questioned in the last 1970. Why? Because sliding scale therapy is failed to adequately control the hyperglycemia, resulted in high rate of hypoglycemia, while associated with longer hospital stays. So this should be discouraged. So what is now we should prescribe the basal bolus therapy. Why basal bolus therapy? Because if I consider this thing, this is the basal. This is the basal thing. It is a natural phenomenon. When I take the breakfast, there is insulin surge. When I take the lunch, there is insulin surge. And when I take the dinner, there is insulin surge. So this insulin therapy is based on this criteria. So if I take the diet, we can add the short-acting insulin or regular insulin, and at the basal we should use the basal insulin. So this is a very good combination, and this should be prescribed. And so I already mentioned, and basal is effective, and it is so it is related to the clinical improvements and reflect in the many strict formal statistics. So substance insulin basal correction. Basal insulin, that is glargine, insulin lactase, non-important hesitate, day-to-day, and day-to-day we can use. So nutritional, we can use the epidural, that is the glucosamine, Nispro, rapid-acting insulin, short insulin, and calcium insulin. If blood sugar is there, blood sugar starts, we can use the calcium insulin. So deciding the treatment approach for the patient of the admission. So we first during admission we should measure the blood sugar level. Okay. So we have already described. I will give the time, so I will go through this thing. I will do this thing. This already described. So instrument management. Decide the patient is already described. There is a protocol, same type protocol. So now is the insulin is the it is the determine the decide if the patient is appropriate for the protocol and the discontinue the disease when I should be calculate the estimated total daily dose, and total daily dose should be calculated in this way. So calculate the weight-based calculation. The total daily dose is required in case of malnourished, elderly, and sick patient, in which can prescribe the body weight in kg into 0.3 normal weight patients, including the type 1 diabetes mellitus 0.4, overweight 0.5, and obese high dose steroid 0.6. We can calculate in this way. So basal goal, we should prescribe the 50%. If total daily dose is suppose 20 units, so 10 units should be basal, and the rest 10 units will be bolus. That is divided doses. So selected a nutritional dose if it is nutritional such, we can add this thing and add calcium insulin and according to dietary intake. So during the discharge insulin algorithm, if it is hemoglobin is less than 7, we can discharge the patient with oral hypoglycemic agent. If it is 7 to 9, it is better to add the basal insulin, and basal insulin dose should be 50 to 80% of the hospital dose, and we can add the oral hypoglycemic agent. And if it is more than 9, we should discharge the patient with the basal and bolus therapy. So if patient is on glucocorticoid therapy, so hyperglycemia induced by a steroid will peak 8 to 12 hours after it is given. So for the according to the FDA recommendation, for the basal insulin, use the IV insulin nutrition or intermittent acting insulin twice daily or the long acting insulin. For the prandial and nutritional insulin, use the insulin regular or rapid acting insulin before meals. If the patient is on non for NPO status, and use the regular and rapid acting insulin every 4 to 6 hours. So minimize hypoglycemia, so it should be considered in mind. And who are taking insulin, older age, greater disease severity, diabetes mellitus, and persistence in oral hypoglycemic agent or insulin, unexpected change, then rapid change, the dietary change or insulin dose, lack of glucose monitoring, and failure to adjust the therapy when blood glucose is trending down or steroid therapy is being tapered. So when it's hypoglycemia, if it is mild, moderate, or severe. If mild, we can give him 5 teaspoons sugar. Okay, there's no response, I can give IV glucose. If repeated, should be 3 times within 10 to 15 minutes apart. If no improvement, then patient should shift in the IV for 25% glucose. And in case we can use the IV intramuscular glucagon also. Moderate, same. And in case of severe, we should institute initially with the 25% glucose. So management in case of the hypoglycemia, in mild to moderate, insulin should be continued. In case of severe, IV insulin should be discontinued. So treatment of hypoglycemic pregnancy, all women with the pre-existing diabetes mellitus and or previous gestational diabetes mellitus should have access to the pre-conception care to ensure the adequate nutrition, glucose control before conception, during pregnancy, and in the postpartum period. Regular and rapid acting insulin analogs are the preferred treatment for the postparental hyperglycemia in pregnant women. Basal insulin can be provided by using the rapid acting insulin via the continuous insulin pump or by using the long acting insulin. And in my conclusion, hyperglycemia is common in hospitals patient. all the hospital patients should have normal blood glucose level. Most powerful agent, we have to control the glucose with insulin, and basal bolus is the preferred alternative in sliding scale therapy. Aggressive insulin treatment improve the ICU outcomes in the post-traumatic patient, cardiac surgery outcomes. And treatment of the mild, moderate, and non-complicated DKA with the subcutaneous administration of the effective insulin are the safe, effective, and alternate to the traditional use of the IV glucose insulin infusion. Patients with severe and complicated forms of DKA, however, should still be treated with IV regular insulin in an ICU setting, and the long-acting insulin analog may have a role in facilitating the transition from continuous IV insulin infusion to the subcutaneous maintenance therapy in patients with DKA. So this picture snap from the Ramla part. So run for the fun to make the glucose diabetes control, and if you have the diabetes parameter, we should go for the regular physical exercise and the healthy diet. Thanks for questions.